Okay, thanks very much, and a really big thank you to the organisers of the conference for inviting me to come and speak. I didn't know when I was writing this talk how important this talk was going to be, but actually so much of what I've heard today already has been about the fact that ultimately the goal perhaps is personalised medicine, predictive analytics. And this encompasses so much of what I'm going to talk about today. So a big thanks to my collaborators, and in particular Gary Collins, who's contributed some slides today, particularly the ones that you don't agree with. They're all Gary's. I'm going to start with this quote attributed to Galen in the 2nd century AD. Patient trust was essential in the healing process. It could be won by a punctilious bedside manner, by meticulous explanation, and by mastery of prognosis, an art demanding experience, observation, and logic. And this idea of prognosis and looking to the future and making predictions is the focus of my talk today. So let's just try and put this into context a little bit. What do we mean by prediction and prediction modelling in healthcare? I realise that my word modelling is outdated. I should be calling it analytics nowadays. So you can substitute models for analytics if you would like. So prediction models are tools like QRisk, which are using multiple components of information, which I might call prognostic factors, you might call predictors, you might call features, others would call variables, information at the individual level that is used in combination to make predictions, for example, of the risk of a cardiovascular disease within the next 10 years. And we're looking for a useful model that provides accurate predictions in individuals to inform them as patients, to inform their health professionals and decision makers, to ultimately improve outcomes. We may also use these things for improving research and within trial randomization and things. But crucially, the focus is on predicting information for individuals, so me as a patient or you as a patient. Traditionally, this would be based on statistical methods like regression models. Nowadays, of course, we might be interested in machine learning methods or those attributed to AI like neural networks or random forests. Here's an example of a object, a web app, which has got behind the scenes a prediction model. And this is for individuals who have had a traumatic brain injury, and the tool called CRASH is used to predict their mortality risk by 14 days. And in this tool, we enter information about the country, the age of the patient, the Glasgow Coma score, and other information, and the tool gives us a prediction. Here for this individual, it's a predicted value of 14%. Can I use the mouse on this? Will the mouse work? No, all right. No point? No. Okay, so 14% for this individual. So that's what I mean, an individualized prediction tool. And these are hot topic. There are many, many prediction models published each year. I'll show you in a second. But you may have heard of some of these, the Framingham Risk Score, QRisk, Nottingham Prognostic Index, the APGAR score, the Leicester Diabetes Risk Score. They inform individualized precision, personalized medicine recommended by NICE. They are very important. Now, what do we need for a tool to be useful? Well, we need the predictions to be accurate as far as possible and clinically useful. And that means that we should understand fundamentally whether these models work. Do they have good performance? Do they calibrate? In people like me, does the observed risk agree with the predicted risk? Does it discriminate? Does it tell me who's likely to have the outcome and who's not likely to have the outcome correctly? And does it provide clinical utility? Do those risks inform decision making? Today I've heard about the goal of all the health analytics that are going on in the NHS is to personalise medicine. Now, does that actually lead to improved outcomes? We need to know. Has the model been shown to work in the target populations of interest? If a model was developed in one system, does it work in another system in a different place, for example? So statistically, that means we need performance measures like calibration plots. For discrimination, you may have heard of things like the C-statistic or the area under the curve. And for utility, we need measures such as net benefit and decision curves. Now, this requires careful statistical modeling. As a statistician, I've not heard the word statistics mentioned too much. I've heard bioinformatics, machine learning. Statistics and reliable statistics and statistical practice should be fundamental in everything that we are doing to make sure that the results we get are reliable. This is one example of a calibration plot. This is for a prediction model for 30-day mortality following an acute MI. This model looks like it's got good performance. The C-statistic of 0.8 is quite high. The O over E is 1. That's the observed of the expected risks, and 1 is perfect. But have a look at the blue line. Now, that shows that the estimated risks are generally too low. So the 45-degree dashed line is perfect calibration, and the blue line there is slightly lower. So those who have a predicted risk of 0.8, the observed risk is about 0.5. So there's miscalibration. Is that okay? Sometimes it might be, other times it might not. We don't often get calibration plots. Okay, so that's just a very quick background of prediction modeling in healthcare and why they're important. What I want to talk and stress about today is bad practice. Steve McLaren, when he was England football manager, said, we have to reduce our expectations of England, and we have the players to do it. And he correctly predicted that. This is the landscape of clinical prediction modeling. This is a slide that's kindly lent to us by Martin van Smeden. It's ridiculous. People are producing models by the second. For example, there's 408 models for COPD prognosis, 263 models in obstetrics, 258 models mortality after general trauma. I'll come on to COVID in a minute. Whatever field you're working in clinically, there will be many, many models available to you. Now, why is that? Well, I think it's just because it's easy to do. People just get a software, fit a regression model, and it's another paper for your CV. Now, sadly, that is true. I mean, I'm joking a little bit there, but it is true. That is generally what happens, is people churn these things out without due thought. Very few of these models are validated in new data. Calibration is rarely assessed. People give you the C statistic, but calibration is not given. The clinical utility is not given. Should we trust these models? The answer is nearly always no. Could they be harmful if used? The answer is nearly always yes. You know, if my prediction is not reliable and you're making decisions based on my prediction, then that could well be harmful. Now, during the pandemic, there's an opportunity for prediction models to take center stage in terms of identifying people at highest risk of poor outcomes, maybe prioritizing them for vaccines, for example. It quickly emerged that models were coming out each day in the literature at the start of the pandemic. So Laura Wynants, Martin van Smeden, and colleagues, including myself and others at Birmingham here, we helped do a prediction model review of models for diagnosis and prognosis in COVID-19. And by July 2020, there were already 169 studies in the literature proposing 232 prediction models. Ridiculous. What about the quality of those? Well, you can imagine, again, people were developing these models with no experience, using data that they just happened to have, and when you examine the quality of these, they were very poor. So in a risk of bias tool called ProBAST, you can look at these 4 domains, and in the participants domain, 42% were at high risk of bias, poor quality. For example, some studies didn't even have COVID-19 patients in. They were simulated data. Some of the predictors were included in the outcome definition. Some predictors for making predictions were not ever going to be available at the time of making the prediction in practice. In the analysis domain, the models were fitted with small sample sizes. There was no accounting for censoring of individuals. There was no validation, no calibration checks. It was appalling. Don't end up in that position in the NHS, where you're implementing these amazing systems that I've heard about today, and then you're rushing the bit at the end, which is going to make decisions for individuals. This is the risk of bias summary. Red is bad. It's bad, isn't it? When we did our final update at the Living Review in the BMJ, it was 2022, we got 731 models by the end. 606 were prognostic, predicting the future. 90% were high risk of bias, but there were 29 low risk of bias ones. But, you have to really search for those to pick them out. It's appalling. We shouldn't be in that situation. Here's just some ridiculous examples. I meant to take the name off, but you've seen it now. So this is an example in 2021 by Guan et al. There it is. They say this simple tree XG boost model conducted by these features can predict a death risk accurately. And amazing. Look at the circled numbers, the C statistic, the error into the curve, a measure of discrimination is 1. Confidence interval, 1 to 1. Now, come on, who's reviewed this? Have a look at the sample size. Internal validation, 16 events. External validation, 7 events. 7 bits of data. No calibration checks. No clinical utility assessments. What about calibration? This is where, you don't get calibration plots, but if you do, you often get spin. Like on the left there, the calibration curve showed a good agreement between the predicted risk and the actual probability. That curve's all over the place. It's nowhere near the red line. On the right-hand side, good calibration, p-value of 1. P-value of 1, if you've got a number of events of 5, you're always going to get a p-value of 1. You've got no information there. It's meaningless. Spin, poor practice. There were some good studies. And just to highlight one, if you wanted to go away and read one, this is one by Gupta et al., who developed this model, very large data sets, using good platforms that we've talked about today, internal, external validations, examined all the different ranges of measures and showed good generalizability across different places in the UK. So you, who I think a lot of you are going to be wanting to do, and maybe are doing already, predictive modeling, how can we do better? This is my challenge to you. Register your projects. Just like any other research, register what you're doing. Publish your protocols. Rather than starting out by developing a new model, why don't you try and validate existing models? You might not need a new model. Focus on validation and replication first before developing the next model with your name attached to it. Include statisticians and health data experts from the outset. Now, Ben mentioned this earlier. Medics don't know everything. Statisticians and health data experts like ourselves, we don't know everything. Actually, I wasn't really trained in predictive analytics when I was a student. So, we need people who are expert in the areas that we're working in, so get them involved in your projects. And crucially, get clinical experts involved to tell you what the research question should be, what tool you're trying to produce to answer what question, to inform what decisions. Clearly report your findings. There's the tripod guidance. Doug Altman said, good reporting is not an optional extra, it is an essential component of research. Transparently report your results. This tool is going to be updated soon to Tripod AI, so look out for that coming out. And the tripod statement, there's also tripod extensions to people doing reviews, for example, of prediction models as well. Don't dichotomize continuous predictors. Now, this is something that happens routinely, and if you automated this in your databases, you may think about dichotomization to speed things up. For example, dichotomizing age into over 65 or below 65. This is ridiculous. You're often throwing away about a third amount of information by doing that. It's biologically implausible. Why is somebody that's 65 different than somebody that's 64? Why is somebody that's 64 exactly the same as somebody that's 23? It's meaningless, bad statistical practice, and is throwing away information. Personalized medicine, and you're dichotomizing my age into high or low. Rather model things properly as nonlinear relationships. You could say, well, hang on, we need thresholds for decision making. Make those decision thresholds on predicted risks. Risk scale, not the value of a feature in the model. Also, go beyond discrimination and even calibration. So a model may have good calibration and good discrimination and be useless. Conversely, the calibration and discrimination may not look so great, but actually it may be worthwhile. Vickers and Cronin argue this. For example, specifying that a patient with cancer is at very high risk rather than just high risk may reflect that the model is a good one, but it makes no difference because high risk or very high risk, the patient is going to be biopsied in both cases in the area of prostate cancer. By contrast, a model with only moderate discrimination might be useful if the clinical decision otherwise is a toss-up about what to do. So it's context-specific about the performance of the model and how it's going to be used and whether it's useful. Let's go back to this model. I showed you this model before, and the calibration plot, I was worried about it. It was the blue lines below the dotted line. There's some miscalibration, but it's mainly at the high end, isn't it? Those with high risk have got too high predicted risk, but they would still perhaps be classified as high risk either way. And maybe clinical thresholds are more down towards the bottom. Maybe they're down towards the 5% or the 10% range, and therefore miscalibration at the top range towards 50, 60, 80% maybe doesn't matter as much. So it could still be clinically useful, this model, but how do we measure that? We could do cost-effectiveness modelling. We could maybe evaluate the model as a health technology tool in a randomized trial. Or we could look at something called decision curves and net benefit, which are complicated measures, but are important and should be routinely reported. They depend on you identifying in advance of the analysis thresholds for decision-making. So if we go back to this model and look at the net benefit for this model, anything above 0 is good. And you can see that for risk thresholds in the lower range between about 0.1 up to about 0.4, the black solid curve, which is telling me the net benefit of the model, that curve is above 0. So this model has a net benefit in making clinical decisions, even though there's miscalibration, if the risk thresholds for decision-making were below 0.4. Okay, I know that's a lot to take in, but I'm just getting the point of clinical utility as another important measure. Also, aim to develop a stable model. Models are more likely to be reliable and stable when they're developed in large sample sizes. You've got appropriate number of predictors relative to the number of events. You use right statistical methods or machine learning methods that account for this issue of overfitting to the data. And examine the issue of instability, for example, using resampling methods, which are known as bootstrapping methods. I'm going to give you some examples about what I mean. Most models are like this. People are throwing things in together, and it leads to instability and impending danger. Now, if you have a very large sample size, I'm going to develop a model here, a lasso logistic regression model. 40,000 patients, 3,000 events, 407 events per variable in my model. That's huge data. And I'm plotting here the variability in individual predictions if I happen to generate a different model with the same sample size. Okay, it's not the same sample, but the same sample size. So if you look at this graph, I'm plotting on the bottom there the predicted risk from my developed model, and on the left is the variability in the predicted risk from other models that I could have happened to generate if I randomly sampled a different sample size of the same size. So look at somebody who's got a prediction of about 0.4. The variability around 0.4, I wish I could point, is very narrow. Okay, so other predictions from other hypothetical models that I could have generated, they go from about 0.35 to 0.45. If I was to develop a model in a small sample size, now look at the variability. So I'm going to flip between those two. Somebody who's predicted risk of 0.4 from my model in a different model may have had a prediction up to about 0.7 or down to about 0.1. Okay? So you develop your model, I develop mine. For one individual, we can get very different predictions. That is not a stable situation, and that is potential harm. What about random forest? Machine learning saves the world AI. If we apply a random forest using default settings, look at the instability there. Look at somebody who's got a predicted risk from my model of 0.8. The variability actually in other models of that type goes from 1 to 0. So you're telling me you're personalizing my medicine based on a model where actually I don't really know anything about it, but my model suggests your risk is 0.8. Somebody else's model down the road suggests it's 0. Don't end up in that situation. And actually, machine learning versus statistical methodology, that's not the debate. It's always about the right methodology to answer the right research question. Machine learning methods have huge potential in this area, but they often need a lot bigger sample sizes. Just be cautious about their stability. If you've got an unstable model, those doing machine learning and looking at explainable AI, fairness checks, some of these things today, it's futile. So sample size is very important. We've provided some guidance, which you can see at the end in our papers, on sample size to target stability. And the package PM sample size in R is something that I'd encourage you to check out. So I'm coming to the end now. It's hard to stop making predictions. And our goal is often to make predictions. Paul Gascoigne once said, "I never make predictions and I never will." Andrea Leadsom, MP, well, she was in December 2018. "I have never and will not start predicting the future. I don't do predictions ever." A few hours later on the radio, "I am a very strong arch-Brexiteer. I genuinely believe that we have a bright future ahead of us when we leave the EU." It's very hard to not make predictions. And in your work, you're going to be involved in projects that are wanting to make predictions. So what can we do to improve the prediction model field? However you identify, and actually we're an amalgamation of all these things, however you identify, whatever your background, whatever your training, whatever method you prefer to use, if you want to work in predictive analytics, you need training. And others need training. They need educating. We need to enforce higher standards because the field is atrocious. We need to aim for stable models that have clinical utility and impact, and focusing particularly on validation rather than developing our new models. So I'll finish there with some selected references and a website for you to check out. Thank you.
Thank you very much. We have 2 minutes for questions. Does anyone want to make me run up some stairs? No one at the back, that's good. No one in the front? Oh, great. Not too far.
Don't know if this works. I don't know if this is for you or for someone else. I think what you're saying is interesting. I think what I find difficult and confusing is, like, earlier people talked a lot about apprenticeship schemes and training right at the early stage of career is like the way to get this investment in this area. But I agree, I think you need the senior people with some experience, right? Data science is a craft. Like, is there any effort to bring those people into this industry? Because obviously they're very expensive, like established data scientists to lead the way on these things for more junior people.
Yeah, I'm probably not the best person to answer that, but we need investment with expertise in all the different areas of these systems and pipelines that we've got. And this is certainly one which I would really suggest statisticians, those data scientists with predictive analytics experience, need to be embedded in that process. It's a good point.
I'm really sorry, Richard, we're going to have to leave that there. So once more, if we could just get a sign of our appreciation, that would be great.